Hello guys, so today we are going to discuss an ECG of a patient who is a known case of CKD on MHD who is complaining of palpitations. So first of all, see the lead position in AVR, it is normal. We will go to the rate. Rate is around 150 as you can see from the two large boxes over here. The QRS complex is narrow and the rhythm is overall regular, so to say. So this is a narrow complex tachycardia. So this is the first thing that we can see. The next thing that we should observe is where it is originating from and to look for P waves. It is a bit difficult to see P waves in the ECG. We will discuss why that is. So in lead V2, I think it is most obvious here that there are P waves. They are hidden in the T waves of the previous wave. I have marked the P waves that are seen over here. And along with that, we can also see a very peculiar pattern of differences in the QRS complex amplitudes with each beat. So this pattern is called as electrical alternans. One important point to remember in this is the baseline or the isoelectric line is the same. It does not vary along with the QRS voltages. So just the QRS voltages are there that are varying and nothing else. Other than this, there are a few things that we can see in the ECG that you might be confused about. One is the ST depression. What is the cause for the ST depression is something that is generally confusing for many people. So, one thing about the ST depression is that it is downsloping with T-wave inversions, which are asymmetrical. This is generally related to some kind of stressor on the LV myocardium, especially when the ST depression is present in V4, V5, V6 and stuff like that. So here what could be the cause for stress on the LV myocardium is one could be LVH. The S waves in V2 are very deep and V5 also shows quite significant R waves. But also the tachycardia. Tachycardia is also a situation where the diastole is inadequate, the coronary filling is inadequate, and the myocardial demand and supply mismatch is quite evident in such conditions. So, generally, in this scenario, it is not to be attributed to something as non ST elevation MI or something else. This is the general overview for this ECG. The cause for electrical alternans, as we will see soon, is generally the most common cause is pericardial effusion. Some pericardial tamponade can also be there depending on the clinical scenario, and other stuff is also there that you can read about. We'll go ahead and discuss in brief of ECG findings in massive pericardial effusion. Massive pericardial effusion produces a characteristic ECG triad of low QRS voltages, tachycardia, and electrical alternans. And tachycardia, low QRS complex, and electrical alternans. Electrical alternans is consecutive, normally conducted QRS complexes that alternate in height. It occurs when the heart swings backwards and forwards within a large fluid-filled pericardium. Okay, we can see here that it is going here and then down. Management: the patients with this ECG pattern needs to be immediately assessed for clinical and echocardiographical evidence of tamponade. Clinical evidence, what would that be? Tamponade that you can read about, but a very brief of pericardial effusion is muffled heart sound is something important. You can look at the BP, you can look at the heart rate, and those are good indicators of clinical decompensation in terms of tamponade or effusion. And one more ECG where you can see the same pattern of alternating QRS complexes with each beat. I hope you understood the topic and can look for these things when you see such ECGs again.